Hi, my name is Mary Vukicevic and this presentation is about optic nerve problems. There are several signs of optic nerve problems and therefore careful examination and history taking of the patient is essential. So patients might present with decreased visual acuity, an afferent pupil defect, colour vision problems, particularly those affecting the red or green wavelength, and diminished brightness of light and visual field defects. What you should consider if you suspect a patient might have an optic nerve problem is that they could have raised intracranial pressure, they might have ischemia, which is associated with atherosclerosis, diabetes, or a condition called giant cell arteritis. They could have intracranial hypertension, and this can be associated with both prescription and non-prescription drugs, or they could have thyroid eye disease. So some of these things could be life-threatening, whilst others are not so much, but it is very important to take a careful history with the patient. So as part of this presentation, I'm going to cover the following optic nerve problems. This will include optic atrophy, neuritis, neuropathies, and papilloedema. Let's start firstly with optic atrophy. Optic atrophy is caused by a lesion of the visual pathway, and interestingly enough, you won't see really much happening at the optic nerve head. There's usually no swelling at the optic nerve head. What you will see is a pale flat optic disc with clear margins, as is shown here on this image. And you'll also see what's called the Kestenbaum sign, which is a decreased number of blood vessels on the optic disc surface. And this optic disc actually looks quite pale, and you can see one or two vessels, but there should be a few more hanging about there. And there's also thinning of the nerve fibre layer. Optic atrophy can be caused by a variety of things, so things such as retrobulbar neuritis, compression somewhere along the visual pathway like a tumour or an aneurysm, some sort of hereditary neuropathy, or a neuropathy related to a toxic substance or a nutritional condition. You can also see optic atrophy appearing in papilloedema. I'll talk to you about papilloedema a bit later. Something called anterior ischemic optic neuropathy and papillitis. Again, I'll cover these topics very shortly. Let's move on now to optic neuritis. Optic neuritis is defined as inflammation, infection, or demyelination of the optic nerve. And it can be classified in two ways: by its appearance, which is the ophthalmic classification, or by its etiology or cause. So if we consider the ophthalmic classification, there are three types of optic neuritis. There's retrobulbar neuritis, which is where the optic nerve actually looks normal initially, and it's often associated with multiple sclerosis. And because it's retrobulbar neuritis, it means that it's after the globe. The inflammation is occurring after the globe, which is why you won't really see any signs when you're looking in at the fundus. The optic nerve will usually appear quite normal. Then there's papillitis. Papillitis is the most common type of optic neuritis in children, and it affects the optic nerve head. The optic disc becomes swollen or edematous, and it's also associated with flame hemorrhages around the optic nerve. So the image at the top here is showing mild papillitis, and you can see that there's sort of blurring around the optic nerve margin, and here is more severe papillitis or swelling of the optic nerve head. You see that you can't really see the optic disc properly, and then in the image here below you've got the swollen optic disc together with those peripapillary flame hemorrhages, which is what I was explaining before. And then finally, neuroretinitis affects the optic nerve head. Any sort of swelling around the optic nerve head is termed papillitis. And other signs of neuroretinitis include retinal nerve fiber layer inflammation and something called a macular star. That's shown in the image below here. So we've got a swollen or blurry looking optic nerve, edematous, and then the macular star appearance around that central area around the macular zone. Neuroretinitis is the least common type of neuritis. So let's have a look at this macular star. There are other retinal disorders which cause a macular star, and therefore how do you differentiate between the two? So macular stars can appear either with neuritis, or they can appear in hypertensive retinopathy. So how do you tell the difference? Well, if it's hypertensive retinopathy, the macular star is usually associated with cotton wool spots, which you can see here in the image on the left. There they are, around the nerve fiber layer, and also these hemorrhages around the nerve fiber layer. Interestingly, and look carefully, the optic nerve appears to look normal. It's got well-defined margins. You can see the cup to disc ratio, but the macular star is there. So this is hypertensive retinopathy. Here's neuritis, optic neuritis, and here we've got the macular star, and we don't have any cotton wool spots or hemorrhages, but we do have a swollen optic nerve. So that's your differential. If you have a macular star with a swollen optic nerve, it's related to neuritis. If you have a macular star with hemorrhages, cotton wool spots, and a nice looking optic nerve, then it's a hypertensive retinopathy diagnosis. So I mentioned before that optic neuritis can be classified according to how it looks or what it's caused by. And here's the etiological classification. So this is what it's caused by. It can be either demyelinating, which the most common cause in demyelinating optic neuritis is multiple sclerosis. It can be para-infectious, and it follows a viral infection or an immunization. And it can be infectious. So something like a sinus infection, cat scratch fever, syphilis, Lyme disease, or even AIDS can cause an infectious optic neuritis. So let's take a look first at demyelinating optic neuritis, and this is where the myelin is lost from the nerve fibers, and losing myelin off the nerve fibers disrupts nervous conduction, and it can be caused by diseases such as multiple sclerosis. You can also have demyelinating optic neuritis just as an isolated case, and often patients with optic neuritis don't have any other associated systemic disease. But about 15 to 20% of patients with multiple sclerosis will present with optic neuritis, and about half of all patients with MS will at some point develop optic neuritis. Patients with demyelinating optic neuritis usually present to the clinic between about the ages of 20 and 50, and they have decreased vision in one eye. Usually around the level of 618 to 660, but it can get better and improve to about 6.9 in 3/4 of cases or so. They also complain of white or coloured flashes or sparkles. These are called phosphenes, and sometimes they can complain of pain, especially on ocular movement, and they often will present with a pupil defect. Now, one thing to note is demyelinating optic neuritis is often retrobulbar. So when you look in at the fundus, the optic nerve appears normal. However, as I said before at the beginning of this presentation, careful patient history is fundamental, because anybody that's complaining of pain around the orbit or pain on ocular movement should be investigated further for some type of neuritis. Demyelinating optic neuritis can also cause visual field defect, particularly in the central 30 degrees, and patients will present with central scotomas or focal defects such as those shown here. So we've got central scotoma on the top left, a central cecal scotoma, a nerve fiber bundle defect, or an altitudinal defect. Let's now take a look at para-infectious optic neuritis. This can be associated with various viral infections, including things that are quite common, like measles, mumps, chickenpox, rubella is not so common, whooping cough, glandular fever, another common one. It can also occur after immunizations, and children are affected more frequently than adults. Presentation is usually about 1 to 3 weeks following a viral infection, and the patients can present with acute severe vision loss, and it can be bilateral. Patients can also present with other features that are neurological in basis, and these include headache, seizures, or even ataxia. You can see papillitis at the optic disc, so a swollen optic disc. Otherwise, the optic disc can look entirely normal. And then finally, of the etiological classifications of optic neuritis, we come to infectious optic neuritis. And this can be associated with things like a sinus infection, which spreads and puts pressure on the optic nerve. And I mentioned before cat scratch fever, syphilis, Lyme disease, meningitis, and varicella zoster virus. So the underlying feature often is the neuritis, which is quite visible when you look in at the fundus and the patient has a swollen optic nerve. One thing to mention here is that often you can't tell initially by looking at the optic nerve what is the underlying cause of the optic neuritis, or the swelling of the optic nerve. It can be a range of things, and so when it's detected, you aren't expected to know then and there what the underlying cause is. You're expected to be able to tell if an optic nerve is swollen or not, but then there needs to be further investigation to determine what the underlying reason for that swelling is. Okay, let's now have a look at optic neuropathies. We can divide up optic neuropathies into two sorts, acquired or genetic. And under acquired optic neuropathies, we have non-arteritic anterior ischemic neuropathy, arteritic anterior ischemic neuropathy, posterior ischemic optic neuropathy, and then Leber's and hereditary optic neuropathy fall under the genetic neuropathies. I'll go through each of these in order. Alright, let's start with the first one, NAION, or non-arteritic anterior ischemic optic neuropathy. This is the most common optic neuropathy in elderly people, and it's caused by an infarction of the optic nerve head because there's been blockage of the short posterior ciliary arteries. And patients will usually present with this problem between the ages of about 55 and 70 years. They often have systemic conditions which include hypertension, increased cholesterol, possibly diabetes, or sudden hypotensive events or low blood pressure events. Cataract surgery can rarely cause this, sleep apnea, and another thing that can cause this is taking Viagra. Patients will present with sudden, painless monocular vision loss, and they'll often realize that vision is reduced when they wake up in the morning. So what to look for? Well, they'll present with a swollen optic disc usually, as you can see here, and they'll have decreased vision, but actually some will have normal or near normal visual acuity, and often they'll have a visual field defect and colour vision loss. So if you're suspecting an optic nerve problem, it's a really good idea to actually perform a colour vision test. Let's have a look at the next optic neuropathy, and this is arteritic anterior ischemic optic neuropathy, and it's caused by something called giant cell arteritis. Patients present with sudden and severe unilateral vision loss, and they can also have periocular pain, so pain around the eye, and maybe photopsia, which is flashing lights. It's really important to have a look and see whether they've got this thickened superficial temporal artery on the forehead, because this is associated with the giant cell arteritis. Other signs and symptoms that a patient may present with include something called jaw claudication, which is a stiff jaw or problems with the jaw when eating or chewing, headache, which has come on recently, scalp tenderness, and scalp tenderness is usually associated with this thickened superficial temporal artery, and weight loss, and a history of polymyalgia rheumatica. AAION has a poor prognosis, and vision loss is usually permanent, unfortunately, and you can have a look here, and you can see the underlying sign when you look in at the fundus is an optic neuropathy. The next neuropathy is PAION, or posterior ischemic optic neuropathy. Now, the diagnosis for this is made after all other reasons for any type of retrobulbar neuropathy are excluded, because it's not very common, and it's caused by ischemia or lack of blood supply to the retrobulbar part of the optic nerve. Because it's retrobulbar and it's past the insertion of the optic nerve head, you're really not going to be able to see any sort of changes to the optic nerve at all. Here's just a quick comparative table between to help you distinguish between NAION and AAION. In NAION, or non-arteritic, you get sudden painless vision loss in one eye, as opposed to arteritic, where there is sudden painless vision loss in one eye, but the patients can also present with photopsia or flashing lights. And 30% of patients with NAION can have normal or near normal vision, whereas with AAION usually there is quite severe vision loss. And also to look out for with that condition is the tender scalp and the periocular pain. And sometimes ladies particularly, or sometimes men, notice the tender scalp when they're brushing their hair. So that's a good question to ask, whether they've noticed any changes around the scalp area when hair brushing. I'm just going to now give you an overview of these genetic optic neuropathies. Now, these are very rare, so it's unlikely you'll ever come across these clinically, but sometimes you will, particularly if you go and work in the low vision setting, and you might have a few patients, children, with these problems. So it's a good idea to just be aware of them. So Leber's hereditary optic neuropathy is caused by a mitochondrial DNA mutation, which is inherited through the mother, and it mostly affects males between the age of 15 and 35 years, and atypical cases can affect girls as well. Patients actually can present between the ages of 10 and 60, so they don't necessarily have to be children when they present with Leber's. But the diagnosis should be considered in any patient with a bilateral optic neuritis, irrespective of what age they are. And sometimes unaffected carriers, so if you're carrying the disease, you can show thickening of the retinal nerve fibers on OCT, but you're not really showing any signs of optic nerve problem. And of course the signs are, swollen optic nerve or a problematic looking optic nerve with large cupping, lack of vasculature, and so on. And then the other one is hereditary optic atrophy, and again, this is quite rare. Patients have a bilateral optic atrophy, and it's associated with conditions such as Wolfram syndrome, and this is where patients have diabetes, optic atrophy, deafness, seizures, short stature, and overall handicap, and something called Behr syndrome, which is spelt BEHR, where again the patient is handicapped and has a spastic gait, so not able to walk properly. So patients will present with bilateral pale optic discs. But again, worthwhile just mentioning these, but they are quite rare, so just keep these at the back of your mind for now. And finally, we're going to have a look at papilloedema. So papilloedema is defined as swelling of the optic nerve head secondary to raised intracranial pressure. It's usually bilateral but can be asymmetrical. So it's interesting to note that not all patients with raised intracranial pressure will necessarily develop papilloedema, but there is a connection between the two. Other causes of optic disc edema in the absence of raised intracranial pressure are referred to as disc swelling, and these usually produce visual impairment. Now, I've written there in red, all patients with papilloedema should be suspected of having intracranial mass unless proven otherwise. So, if you see a patient with bilateral swelling of the optic nerve head, assume that there is a intracranial mass, a tumour, something compressing the optic nerve, and that patient urgently needs to have a brain scan. There was a case recently in the United Kingdom where an optometrist saw a patient with papilloedema, swollen optic nerves, and didn't refer them on for swelling, potential swelling or intracranial mass, and it became quite complicated for the poor patient. So, papilloedema in both eyes, assume that there's some sort of compressive lesion. And of course, you're always going to see this sign of swollen optic nerve. Patients will complain of headache, sudden nausea and vomiting, drowsiness or deterioration of consciousness, transient visual obscurance. What this is they actually come and sit down in the chair and say that there's something going on with their vision. Comes and goes, not quite right. They can't really define what's going on, but they do indicate that sometimes they can't really see properly, but when you go to question them further, you're not getting a definitive answer. So it's very important to carefully question. They can also get horizontal diplopia because there can be a nerve palsy related to it, and there are 4 stages of classification which you might read about, and these are early, established, chronic and atrophic. So to finalize, we covered optic atrophy, optic neuritis, various neuropathies and papilloedema. And usually the common feature here is a swollen optic nerve, either unilateral or bilateral. Now, it's expected that you'll be able to identify a swollen optic nerve if you find one. It's also expected that you'll be able to understand the different causative factors, but you may or may not be able to make a differential diagnosis because the patient may need other testing to rule out problems. However, bear in mind that patients will present with usually decreased visual acuity, afferent pupil defect, so it's very important to check pupils carefully, colour vision impairment, problems with identifying brightness of light, and visual field defects.